Hey, what's up, everybody? So I was also asked after that last ventilator review to do a little bit more. And so what we're doing this time is simply you've got the initial settings. Now this is in that peri-application phase where you've got the settings. You just apply the vent to the patient. Let's go look for some alarms. And these are some things to help you look for alarms and really just mitigate them. So here's some alarm mitigation. Hope you enjoy it. All right, to mitigate alarms with the ventilators, and this goes across multiple different ventilators, almost all of them. There's four major things that could really cause a low VE minute volume or a low VTE situation. So we're not getting them enough air. Could be that they're air trapping or breath stacking or auto peeping. Basically, we are just holding on to trap gas, and then that can build up and that takes away from our lung real estate. So we breathe out less air. So we verify that with auto peep. Auto peep should be 0. If it's not, then we need to reduce our rate or increase our E time to be able to have more time to exhale. For a small leak, you simply fill that pilot bulb. If the pilot bulb is intact, you're good. There's no small leak. Pressure control set too low. If you're in pressure control and it's set too low, then you might not be giving enough essentially volume, but we give it by giving pressure control. So increase your pressure control number. Dead space. And you can only get this if you're in volume control. If you're in volume control, then sometimes because of the length of the tubing and a bunch of other factors, the air just doesn't get to their lungs and there's just dead space that's not happening. And so we need to correct that. One of the easiest things to do is to put them in pressure control, because pressure control eliminates dead space, all right? Because it pressurizes the whole circuit all the way down to their lungs, not just puts air into the tube, hoping it's enough. All right, let's go to the next one. Number 2, let's look for a high VE or VTE. This could be because of a sensitivity that's too low, meaning that as the aircraft or the vehicle wiggles and jiggles as it's transporting the patient, can false trigger the vent thinking the patient's taking a breath. The air could jostle past a sensor and the vent thinks that the patient's taking a breath. So it will start a breath. So you can also see if this happens and they're not trying to physically take a breath, then you might see a flat top end tidal waveform. That can kind of help confirm it. Just increase the sensitivity setting. This makes it harder to fake trigger a breath. All right. There also could be a situation where there's just not enough sedation. This is on the end tidal when we see that curare cleft. If we see that, they give them more sedation, right? Pretty simple. There's a big one, okay? So these seem really, really simple. If you have a low O2 alarm or no O2 or whatever the vernacular is, if we have a specific ventilator, check to make sure that the oxygen tank is plugged into the ventilator and there's a good connection. Make sure that the oxygen tank is cracked open, or on your ambulance that it's cracked open, or it's ultimately the oxygen is on. And then, of course, check to make sure that you have oxygen. So pretty simple here, but this could be like a 3-step process. If you keep that built in your mind, you go boom, 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 you just double check it. You can eliminate this from ever happening, creeping up on you, especially if the patient's getting really, really sick right there in front of you. Now, if you get a high pressure alarm, one of the first things we got to look at is either airway resistance, the problem of air getting down in there, or the lungs, the condition of the lungs. So the lung compliance is really the condition of the lungs. It should accept air and stretch and be a little bit elastic. If it doesn't do that because it's infected or it's got a bunch of mucus or it's inflamed and it doesn't want to expand, that is poor compliance. Okay, so we'll get to that in a second. High resistance is really just airway problems inherently, like there's fluids, kinks, in the tubing, clamped, bronchoconstriction. All that could lead to a higher PIP, but you can have a high PIP and their plat be normal. PIP talks about airway resistance. P-plat talks about lung compliance. So if you have a high PIP and the plat is normal, lungs are great, but the airway pressure is bad. So do your dope mnemonic and clear out whatever's in the way in the airway. And so suction out fluids, do bronchodilators if you need to, something to open those airways up. If the P-plat is high, then what's happening is the pressure is overall high or the PIP is high because the P-plat pushed it up because the lung is not compliant. You're putting a certain amount of volume and the lungs aren't compliant with it. And so if you're in pressure control, you'll get a tiny, tiny VE, but a higher pressure. Typically, you're not going to get a high pressure alarm with pressure control because you're controlling for pressure. But if you're in volume control, this is where you'll see this, is that you put in 500 mils and only 300 goes in, and the lungs aren't moving and you get a high pressure. And that'll go off. So the fix there is for poor compliance, switch to pressure control. The fix, if you have an airway resistance, just clear it out. Be sure to like, follow, comment, and subscribe. Let me know what you want to see next. Thanks for watching.